A patient come to your OPD with recurrent abdominal pain, systemic manifestations like fever and weight loss. What would your differential diagnosis come? Probably IBD. Welcome to my channel. I'll explain about IBD in detail and its medicine aspect. Inflammatory bowel disease. It is an ongoing inflammation in the digestive tract. Diseases in these are Crohn's disease, ulcerative colitis, microscopic colitis, diversion colitis. Looking at epidemiology, overall diseases occur more in males than females. For Crohn's disease, it's most among females than males. It has bimodal age distribution. Its first peak occur in 15 to 30 years and second peak in elderly people. Coming to races, Jewish and non-Jewish, African, Hispanic and at last Asians. Let us look at features of Crohn's disease. Aphthous ulcer. Aphthous ulcer coalesces to form serpentine ulcer, which is snake in shape, as you can see. Skip lesions or non-continuous lesions, deep knife-like lesions, which are transmural, involving all three layers. These also have cobblestone appearance of the mucosa with creeping fat. This is the cobblestone appearance and this is the creeping fat. Coming to ulcerative colitis features, it spreads in retrograde manner and most common site is rectum. It involves only submucosal layer, whereas in Crohn's disease it's transmural, all layers. Next, coming to ulcerative colitis, these form pseudopolyps which fuse to form mucosal bridges. All over from rectum to ileum, it causes lesions, continuous lesions, which also called as backwash ileitis. Smoking is protective in ulcerative colitis, whereas in Crohn's disease it's causative. Coming to ulcerative colitis features, we have also cryptic abscess and cryptitis. Appendectomy is also protective for ulcerative colitis. Let's look at genetic disorder association. All IBDs are associated with Turner's syndrome. And also, Crohn's disease is commonly seen in glycogen storage disorders type 1. Also seen in Hermansky-Puldak syndrome. The patient will appear as albinism and bleeding. Coming to ulcerative colitis in Wiskott-Aldrich syndrome. Looking at genetic association, Crohn's disease, the gene responsible for Crohn's disease is NOD2 gene, which is located on chromosome 16. This gene defect causes in defective autophagy and also defective release of defensins in parent cells and also dysregulation mucosal immune response. Coming to antibodies associated with Crohn's disease are anti-OMPC, which is anti-outer membrane cellulated protein antibody. Associated are HLA-DQ, HLA-DR, HLA-DR3 and MDR1 gene. Clinical manifestations of first ulcerative colitis, which is common with proctitis, which is inflammation of rectum, and also it presents with stools, blood, pus and mucus. Tenesmus, it is a sensation of recurrent bowel, but you are unable to defecate. The markers which is present in ulcerative colitis are lactoferrin and calprotectin. Calprotectin is very highly sensitive and non-invasive marker. Coming to Crohn's disease, and its features are ileocolitis, and the patient presents with recurrent episodes of pain in right lower quadrant, and it also presents with systemic manifestations. Whereas in ulcerative colitis, mostly systemic manifestations are not present. Let us look at endoscopy of ulcerative colitis. We do colonoscopy and find out for any erythema. Erythema can be mild, moderate, and severe due to its decreased vascularity, or moderate due to its vascular leak and spontaneous bleed for its severe. This is a picture of endoscopy. See, you can see normal mucosa over here and slightly inflammation over here, and vascular leak and erythema and spontaneous bleed over here. Let us look at radiological findings of ulcerative colitis first. There is collar button stud appearance, as you can see over here, and then you have granular mucosal ulcerations, you can see over here, and lead pipe appearance. Coming to Cons disease, there is string sign. You can see the string sign over here, which appears as rose thorn. Ulcerative colitis can also complicate as fistula, fissure, malabsorption, and stricture. Coming to CT scans, we have mostly Cons disease can be ruled out or found out by CT scans. Cons disease have fat halo, you can see over here, and then target like appearance like this, and then thickening of the wall. Let us look at management of IBD. Coming to ulcerative colitis, Doodle and Witt's classification. Mild, 4 stools per day. Severe is 6 stools per day. Fever is absent in mild and present in severe. Coming to heart rate, which doesn't increase prominently in mild forms, but it goes more than 90 in severe forms. Coming to Cons disease, in mild forms, weight loss is less than 10% and no symptoms. But moderate, increase in temperature and prominent weight loss with nausea and vomiting. In severe forms, there is bolus obstruction, as you can see over here. Let us quickly go into treatment of ulcerative colitis first. 5-amino-salicylic acid plus sulfasalazine are useful in ulcerative colitis. This have been 5-amino-salicylic acid have been part of treatment for ulcerative colitis since long. But its main problem is it doesn't take up till the rectum. It just absorbs in small intestine, and that's why we give 5-ASA with sulfasalazine. But there are drawbacks with sulfasalazine. It gives hypersensitivity and folic acid deficiency. That's why we use 5-ASA, which is amino-salicylic acid, which is delayed release into the intestine and go until your rectum, which is mesalamine. Now, for mild forms, mesalamine is enough. And to treat moderate forms, mesalamine plus steroid is important to give. And for severe forms, steroid, which is IV, plus anti-TNF alpha, which is an immunosuppressant. Ulcerative colitis, budesonide have been treatment for over a long time. In moderate forms of Cons disease, steroid plus methotrexate is given. In severe forms, IV steroid plus anti-TNF alpha is given. Indications for surgery are toxic megacolon and also perforations and dysplasia of the colon and the bowel intestinal mucosa, also hemorrhage. So this is a view over inflammatory bowel disease. Like and share if you like the video. Thank you.